Thank you very much for this opportunity to talk about the role of germline pathogenic variants in endocrine sensitivity of breast cancer. These are my disclosures. So when we think about germline pathogenic variants, among patients with or women with ER-positive breast cancer, approximately 4% will have germline pathogenic variants in ATM, CHEK2, BRCA1, BRCA2, or PALB2. When we look at ER-negative, that number jumps up to roughly 7.5% or approximately 8%. What we and others have also shown in the past is that when we look at ATM and CHEK2, they primarily lead to ER-positive breast cancer, and they are not really triple-negative breast cancer, genes associated with triple-negative breast cancer. Whereas BRCA1, BRCA2, and PALB2 increase the risk of both ER-positive.
Thank you very much for the introduction. I'd like to quote Monty Python first, now to something completely different, because the only common denominator to our both topics is that it's about germline mutations. Now I'd like to talk about digital tools and patient communication, so therefore it's a little bit different than what we heard before. These are my conflicts of interest. Fortunately, in recent years, medicine has been catching up in using digital tools for patient-doctor communication. This random selection of actually digital tools that are in practice today show us how digital technology can be used, like preparation of counseling, in education of patients, and also in automatic delivery of results. In Germany, the situation is slightly different.
Thank you so much for the invitation, and I apologize ahead of time because my brain is not working very well. I made the mistake of starting my travel yesterday back home and arrived just a few hours ago. So it's 10 a.m. at home, so I've been awake for 24 hours with 2 hours of sleep before coming here. So sorry if I'm a little less functional right now. So I'm going to be talking about triple-negative breast cancer and specifically focused on biomarkers to make decisions about escalation of treatment and de-escalation, which is obviously an area of interest in this disease and many other of our cancer subtypes. These are my disclosures. And just as a brief overview of what we'll be covering, so we'll start with the main clinical application that we have right now is that response to neoadjuvant chemotherapy remains the most robust biomarker to prognosticate risk of triple-negative breast cancer, and it aids decisions regarding